Thank you to everyone for joining tonight's webinar, Partnering to Provide Personalized Care, Patient Selection for Extended Endocrine Therapy. Tonight's webinar is hosted by Biotheranostics, a Hologic company, and my name is Susan, and I will be facilitating tonight's webinar. We are pleased to be joined by Dr. Rena Callahan, a hematologist-oncologist at the University of California, Los Angeles, as well as Katherine Cohen, a hematology-oncology nurse practitioner, also at the University of California, Los Angeles. After my brief introductions, I'll turn the program over to Dr. Callahan and Katherine Cohen for their presentations, and then we've allotted about 15 minutes at the end for question and answer with today's webinar attendees. Following the Q&A, the webinar will conclude. Just as a reminder, we encourage you to ask your questions throughout today's program. There is no need to hold them until the end, and we will put those into the queue as your questions come in. So please feel free to utilize that Q&A box at the bottom of your screen. And you can also send us a chat if you have any questions or comments. And we will have dedicated time at the end for questions. And with that, I will stop sharing my screen and invite our presenters to go ahead and get started.
All right, so we are very excited to be here tonight. I am Rena Callahan. I am a medical oncologist. I focus on breast cancer research and treatment at the University of California, Los Angeles, both at the main campus as well as in our satellite site a little bit farther north in Santa Clarita, where I work very closely with Katherine Katie Cohen, who is an excellent nurse practitioner who you'll also hear from tonight. And it's our pleasure to be able to speak with you about breast cancer index and where it fits into the very important decision that we need to make about duration of endocrine therapy. This is what we will go through over the next half hour. We'll go over some recently published data and guidelines for extending endocrine therapy decision-making, how we collaborate, the medical oncologists with the advanced practice providers in our management of breast cancer survivors. And then we'll get into some real-world cases. These are cases that Katie and I share, and they have been, hopefully that will show you how we use this important tool in action. So take a look at this graph. I use it a lot in my clinical practice with patients, often at the beginning of their endocrine treatment. And what this is it's a meta-analysis. So an analysis of 100 trials, over 10,000 patients who have received endocrine therapy, in this case with tamoxifen or placebo, for about 5 years. And what I tell them is that, okay, so you see the number of years across the bottom and the percent recurrence on the vertical axis. And so you can see that between years 0 and 5, there is a difference in recurrences between the tamoxifen-treated group, which is the light blue on the bottom, and the placebo group, which is the dark blue on the top. Recurrences are higher in those patients who were treated with placebo. But what's really interesting about this is that over time, you stop taking tamoxifen at 5 years, and at 10 years, you can still see the difference. It's just as much of a difference. And at 15 years, you can see the difference. And that difference is still large. So when I speak to a patient about this, it's that our decisions that we make right now affect your rate of recurrence and mortality 15 years from now. And in this way, a lot of patients decide that, yes, it makes sense for me to take tamoxifen in the first 5 years. But what this also shows us is that the risk of recurrence doesn't stop at 5 years, that it continues 10, 15 years, and even 20 years. And so I've had patients point this out to me. And, the reality is that half of the recurrences occur in the first 5 years, but the other half occur after 5 years. And so there's no celebration at year 5 where a patient with estrogen receptor positive breast cancer can say that they are disease-free for the rest of their life. So we need to make decisions to try to change that over the years. So if the hormone blocking therapy can do a really good job in the first 5 years, why not extend it? And then we can see that further on, there are fewer recurrences at years 10 and 15. And so, yes, we can do that, but we know as practicing clinicians that this comes at a cost. And there are side effects that are associated with extending therapy. And that even while therapy will benefit some, about 1 in 5 patients, most of them, 80%, will not benefit from this extension of therapy. So we need a better way to decide who's going to recur and who's going to benefit from extending therapy. So I'll hand it over to Katie to discuss or introduce Breast Cancer Index to you.
Thank you. So I know that Dr. Callahan talks about this with her patients because I will have patients at follow-up visits say, oh yeah, I saw a graph. I'm like, I know what graph you're talking about. I've seen that graph. I've seen that graph too. So just know, Dr. Callahan, that it makes an impression. They remember it. All right, so tonight we're going to talk about Breast Cancer Index, which is a biomarker tool. And it helps us decide if a woman is likely to benefit from extending her endocrine targeting therapy from 5 to 10 years. And it does that by essentially answering 2 separate questions. And those 2 questions are, does she benefit from therapy? And then what is her risk of late distant recurrence? So that's a recurrence between years 5 and 10 after diagnosis. And so before I go into too much detail about how the test works, I want to talk about a predictive test versus a prognostic test, because I think it's important to understand the difference. So in medicine, when we think about a prognostic test, those are tests that give us information about risk or the likelihood of an event happening. So for example, the likelihood that a woman develops breast cancer in her lifetime, or in this case, the likelihood that our patient has a breast cancer recurrence. That's a prognostic test. A predictive test is different. A predictive test gives us information about the likely benefit from some kind of intervention or treatment that we do. And so Breast Cancer Index is both. They put both of them together. And so focusing first on the left side of the screen, the predictive component of the test. This is the part of the test that is ultimately answering that question, does my patient benefit from therapy? And it's a yes or no answer. And they do that by looking at 2 separate genes. And these genes are used to create a ratio, which is used to create a biomarker. And if that ratio value is high, then the answer is yes, the patient is likely to benefit. And if that ratio value is low, then the answer is no, they're not likely to benefit. And if I think about what this represents inside the cancer cell, it's an estrogen signaling pathway. So that's one part of the test. The other part of the test is the prognostic part. Now, this is the part of the test that is telling me what is my patient's risk of late distant recurrence between years 5 and 10. And it answers this question by looking at an assay of 11 different genes. And if the patient was lymph node positive at the time of diagnosis, it also incorporates tumor size and tumor grade. And if I think about what this is ultimately reflecting inside the cell, it's cancer cell proliferation. And so then those 2 parts of those tests are combined to create what's on the next slide, which is this. This is a snapshot of the test report. So in the center of the screen, you see a snapshot of what a yes report looks like, and the bottom right of the screen is a snapshot of a no report. And so starting with the yes report, you can see that that predictive value was high, that biomarker was high. The answer is yes. And then underneath it, you're going to see for these patients two types of numbers for the prognostic value. And the first that you see that represents that 8%, that's their risk of recurrence if they do nothing. Okay, so that is their risk of recurrence between years 5 and 10 if they do not continue on their therapy. And then those values that you see right next to it, that 2.6 to 3.4, that is the patient's risk of recurrence between years 5 and 10 if they continue on their endocrine targeting therapy, whatever it is, an AI or tamoxifen. And so the difference between these two sets of values, the 8% versus the roughly 3%, represents a 65% relative risk reduction. So that's the yes report. The bottom right of the screen is what the no report looks like. So that biomarker was low. The result is no, they are not likely to benefit from extension therapy. And then below it, you're going to see that one number for the prognostic value. And that's the patient's risk of recurrence between years 5 and 10. The test reports are really this easy to read, which I appreciate. It's a busy clinic. Sometimes the medical assistants are printing them minutes before we walk into a patient's room. And so I appreciate having something that's easy to interpret while I'm walking down the hall. Dr. Callahan, what are your thoughts like when patients get this report?
Yeah, I mean, I think that this report, it's very, very clear. Sometimes we have to go over it a few times, right? Because you have the yes, and then you can say, okay, at 5 years, your risk in this case would be 8%, but if you extended it, it would be closer to 3%. And they understand that, but with a no, that sometimes takes a little more time because it's 8%. I still get the question, well, then what would happen if I extended therapy? I'm like, we just talked about that. But I seeing it like that and saying a no means the number doesn't change gives them something to hold on to. And I think they ultimately do get that.
I agree. I've had those same conversations. Okay, would you mind advancing the slide? All right, so BCI, support for BCI is strong in our oncology world. It's been incorporated into both the NCCN and ASCO guidelines. And here you see the verbiage for both. So we'll start with the left side of the screen, the NCCN guidelines. They state that those who had a high biomarker value demonstrated significant improvements in disease-free survival when adjuvant endocrine therapy was extended. And then those who had a low value for their biomarker demonstrated a lower risk of distant recurrence and were unlikely to benefit if therapy was extended. And then on the right side, you see the ASCO guidelines. They state that BCI may be offered to patients with 0 to 3 positive nodes who receive 5 years of endocrine therapy without evidence of recurrence to guide decisions about extended endocrine therapy. And I also think it's worth pointing out that within these same guidelines, it was noted that Oncotype and EndoPredict and Prosigna, and then also the Ki-67 and the IHC4, they were identified as having insufficient evidence to guide decisions about extending endocrine therapy. So only BCI is really supported in this space for this decision. And here we see some of the genomic assays that have been incorporated into the practice guidelines for NCCN in that breast cancer space. I think we're familiar with all of them. Okay, they include Oncotype, MammaPrint, Prosigna, EndoPredict, and then at the bottom of the screen you see breast cancer index, and you can see that while all of these tests are prognostic to a certain extent, okay, they're all giving us information about some kind of risk. There are only 2 tests that are predictive, and that's Oncotype and BCI. And Oncotype is predictive of the benefit of chemotherapy only, and breast cancer index is predictive of the benefit of extension of endocrine targeting therapy only. And this is supported by level 2A evidence. Next slide.
So the test, breast cancer index, which is now incorporated into guidelines, it didn't get there easily. You know, being incorporated into ASCO and NCCN guidelines is a very high bar. And so the test has been around for several years, but has accumulated robust data, including thousands of patients, 4,500 patients across validation trial after validation trial after validation trial. And so finally, 2022 was incorporated into the guidelines. And this is a snapshot all on one slide of 5 validation trials. So there was initially the Stockholm trial, which included 600 patients treated with tamoxifen or no therapy at all. And so it was an old, proof of concept trial. This is not the way we treat patients, obviously now. But when breast cancer index was applied, you could see that in the yes group, there was a 65%, so a 2/3 relative risk reduction in metastatic recurrence with the use of endocrine therapy, tamoxifen. Now, moving on across the slide, you'll see how we give endocrine therapy now. So there's MA17, which was a trial of tamoxifen for 5 years. And then if patients were disease-free, they were randomized to receive aromatase inhibitor or placebo for another 5 years. This trial, the validation set included about 250 patients. And again, we're seeing when you apply breast cancer index and you get that yes result, that there's a 65%, a 2/3 risk reduction with continuing endocrine therapy, continuing on to the aromatase inhibitor for another 5 years. What's more is that if there is a no, there is no benefit. This was seen in TransAtom, which was a 5 years of tamoxifen, followed by either 5 years of tamoxifen or stopping. The IDEAL trial, which for the first 5 years included tamoxifen, aromatase inhibitor, or a sequence of both, followed by aromatase inhibitor for 2.5 years, or aromatase inhibitor for 5 years. Again, we're seeing that relative risk reduction of about 60%. And that's, what really struck me about the IDEAL trial is that one would think that it would be difficult to see a difference between 2.5 years of treatment and 5 years of treatment. But the biomarker, the breast cancer index test, was able to make this distinction and really pick out those patients that would benefit. B42 was another trial with very large validation set of about 2,200 patients that for the first 5 years received aromatase inhibitor or tamoxifen followed by aromatase inhibitor, randomized to receive aromatase inhibitor for 5 years or placebo for 5 years. And again, we see this 2/3 relative risk reduction. So while there were a variety of endocrine therapies, so tamoxifen, AI, or both, and the patients had varying nodal status, node positive or node negative, what was consistent was that if the BCI was yes, you had a 2/3 risk reduction in recurrence, metastatic recurrence, with extending endocrine therapy another 5 years, versus no benefit if you extended therapy if you received a BCI no. So what this is telling us is that risk is not equal to benefit. And Katie touched on this, just because a test is prognostic doesn't mean it's predictive. So as practitioners, we like to look at what's in front of us to help us make decisions. And so what is that? It's the pathology report, which reminds us of a patient's tumor size, grade, nodal status. We look at the biomarkers on the path report, which include estrogen receptor, progesterone receptor, and 40% or 90%. So that's the quantitative ER and PR, and try to draw information from that, as well as the Ki-67 index, which is the marker of cell proliferation. CTS5, which incorporates patient and tumor-specific factors into a risk calculator, as well as other genomic assays, right? Wouldn't it be great? You already sent the Oncotype several years ago to determine whether chemotherapy would have any benefit. Can't you use it for this purpose? And the short answer is no, you can't. You can't use all of those things. They can, those clinical pathologic factors can give us information on prognosis, but they cannot predict the benefit of whether or not it's helpful to continue endocrine therapy. And that's why in the guidelines, only breast cancer index is positioned here as a genomic asset that can predict the benefit of extending endocrine therapy. So why do we want this test again? To help make decisions. It's a very important decision because a metastatic recurrence, a stage 4 recurrence, is typically life-limiting. But we want to personalize this. We don't want to over-treat patients, but we don't want to under-treat patients either. And we'll get into that shortly. But a test is only useful if it actually causes a change in our thinking, a change in what we do as practitioners and what the patients do. So as practitioners, 40% of our treatment recommendations related to extending endocrine therapy in this study, which was published recently in March of 2024, led to change following BCI testing. So in this study, there were surveys pre and post BCI testing for both physicians as well as patients. And so that's where about 800 or so patients, 800 or so physicians. And this is where this number comes from, that treatment recommendations change between that survey pre and post. So that's telling us that this is a useful test, that we're actually using the information to make an impact on how we treat patients and what we recommend.
All right, so as Dr. Callahan touched upon, the clinical and pathologic features alone might not give us the whole story about our patient. And you will find that when you talk with your patients, or you may have already found this, about the importance of breast cancer index and how it can be helpful, the patients sometimes they will cling to things that you discuss with them, rightly so, about their risk status, their lymph node status, how high their Ki-67 was. And so that can be a reason in their mind for maybe why they don't necessarily want to de-escalate their therapy. And so then at that point, we talk about tumor biology and how there are other factors that help us make that decision. Because remember, as Dr. Callahan said, being higher risk doesn't necessarily equate benefit with a particular therapy. Next slide, please. All right, so for example, BCI found that for patients who have what we would traditionally consider to be high-risk disease, so patients with N1 disease who have a positive lymph node, that approximately 1 in 5 or 20% of those patients were actually at a low risk for a late distant recurrence. And more than 2/3 of those patients were unlikely to benefit from extension of therapy. And so if I'm not using this test, then I would have said something to the patient like, the cancer was in the lymph nodes. It makes sense for us to do everything and anything possible to help prevent a recurrence. And that includes continuing your therapy to 10 years. But approximately 20% of the time, I would be wrong. I would be incorrect to advise the patient to do this. And the problem when patients are continuing on therapies that they don't necessarily need, you are continuing the amount of time that they might experience whatever side effect they're experiencing, and they can be quite limiting, right? They can really inhibit their quality of life. And you're also increasing the amount of time that your patient can experience an adverse event. So those are very real risks with these drugs. With tamoxifen, there's the concern about endometrial cancer and blood clots. And with aromatase inhibitors, we're concerned about bone density loss. And bone density loss sometimes is very mild and sometimes it's not. You know, your patients can develop significant osteoporosis and potentially develop a fracture. So if I can use all the information possible in order to guide patients to make decisions where I can potentially de-escalate their care, then I definitely want to do that. Next slide, please. All right, so going into my first patient case. This patient, she was 49 at the time of diagnosis, and she had initially self-palpated a right breast mass. The workup was completed. She underwent a right breast mastectomy, and here you see the final pathologic staging, which was T1C N1, ductal histology. She had that positive lymph node. She had not a small tumor, you know, just shy of 2 centimeters, low grade, strongly ER/PR positive, HER2 negative, and a low Ki67. So we initiated her on ovarian suppression plus an AI, and she definitely did not have an easy time of it. She had mood swings and hot flashes. These were helped by venlafaxine, but they certainly didn't eliminate the problem altogether. She complained of sexual dysfunction with vaginal dryness, difficulty with concentration, so cognitive changes, and just, you know, not unhappy, but not totally happy, you know? So breast cancer index was ordered at year 4, and then this was the result. Her predictive value was no. So no, she's unlikely to benefit from therapy. And that could be a little bit surprising, right? She had that one positive lymph node. I think many people would be inclined to continue therapy based on that. And then you see that prognostic result, and it doesn't get any better than that at 1%. And so clearly these are results that I think the patient was pleased to get, and the planned end of her aromatase inhibitor is in December of this year. But I've seen her occasionally, but it just worked out that Dr. Callahan is really the one that's been following her case most closely. And I know that you're the one who gave her these results. So how about
this is the best result you can give a patient.
Yeah.
This is great. And it's just clear, you know, I've got great news for you. And, you know, patients, they want the no. I think most of them want the no, but sometimes the prognostic result is not as favorable. But with the no and the 1%, it was an absolute slam dunk. There was no guilt in discontinuing therapy. And, you know, she felt great about the result. There wasn't any conflict. We were both completely on the same page. So these are the results that I really like to give. And it's not always like that. And so we'll go through some of our other cases, right, where it gets a little harder.
All right. So this is our second patient case. And I do not mind saying that this is my favorite patient. It's probably like children. You're probably not supposed to have favorites, but I do. And it's this patient. So she was 31 at the time of diagnosis. She had initially self-palpated a left breast mass, and she had noted left nipple changes and some skin flaking. So workup was completed. She ultimately underwent a left breast lumpectomy, and here you see the final pathologic staging, which was T1C and 0, but with micromets in one of the lymph nodes. So some other factors, she had ductal histology. She had not a super big tumor, but not a super teeny tiny tumor either, 1.5 centimeters, high grade, strongly ER positive, HER2 negative, a high Ki67, and then also a high oncotype score. So one of the reasons that I love this patient is because she is so positive, but also because she is so willing to be a partner in her care and just do whatever it takes, right? So we recommended chemotherapy clearly, and she started it and she completed it. And then she did radiation therapy. And then we initiated her on an ovarian suppression plus an AI. And she had all the side effects. And you just see that. You see that in this age group. She was 31 when she was diagnosed. And this is a time in these women's lives when they're like flooded with estrogen, and then you take them and you drop them and they feel it. And so she had fatigue and vaginal dryness, and she was always very achy. She had the arthralgias. At some point, we repeated her bone density scan, and she had developed osteopenia. And the thing is that she would have continued this for as long as we asked her to. She is so motivated. And we ordered breast cancer index a little bit later than we typically do. You know, our standard is more like 4 to 5%, or between years 4 and 5. But we ordered it at 5.5 years, and then this was the result. And that predictive value was no. And her prognostic score was not super high, not super low, but not super high. And she was thrilled. She was so pleased to get these results, because she wasn't unhappy, but it was a struggle. And when I gave her these results, she cried. I may have cried. And she has since discontinued therapy. And she told me at one of our more recent follow-ups that she feels like she got her life back. And I just can't, I can't want anything more for patients than that. You know, the whole purpose of what we do for these patients is we take them through a time in their life that's very difficult. And then our goal for them is to get them to the other side and have them just return to their life. And I feel like that's what she's done.
Right. And especially, you know, she was only 31, so she's still very young.
Mhm.
So she's got a lot of life to live. And some of her struggles, you know, we talk a lot about some of the more serious adverse effects of therapy. Of course, you know, osteoporosis and fractures can increase mortality, right? Hip fractures increase mortality. But there are also the day-to-day things, right? Just how you feel and things that we're learning more about, like cognition. That's something that I hear a lot about, and it's very difficult to quantify the effects of endocrine therapy on cognition, but we see it all the time. So I think that mattered to her. This patient in particular always struggled with her weight in a you know, a way that she was always very positive about everything, but this was clearly something that had affected her life. And a lot of our therapies, you know, endocrine therapy is associated with weight gain, and that matters for self-image and goes beyond just, you know, is somebody being vain? It's so much more than that. And so she's doing great. She had bariatric surgery, actually has lost a ton of weight. She looks and feels great. She's exercising all the time. It's pretty amazing.
All right, so 71% of, oh, sorry, your turn.
Yeah. Okay. So, all right. So now we're going to take it the other way, right? So we looked at patients with higher risk features who were unlikely to benefit. So we don't want to over treat them, but it's also really important to avoid under treatment, right? To pick out the wolf in sheep's clothing, the assumed clinically low risk T1N0 patients, because those patients have a risk of late stage 4 recurrence that will limit their life. And so we need to figure out who these patients are and not just stop therapy at 5 years, because we could save a life. And in this study presented here, BCI was able to identify a quarter of patients, 1 in 4, is likely to benefit from extending endocrine therapy and at high risk of late distant recurrence who had clinical low risk features, so T1N0. So in this, for this patient, 57 years of age at diagnosis, node negative, 1.3 centimeter grade 2 tumor, so stage 1, estrogen receptor positive. She was also HER2 positive, Ki67, 25%. So she received chemotherapy and HER2 directed therapy, but that's not enough, right, for our patients who are both HER2 positive and estrogen receptor positive. So we spoke about endocrine therapy. She wanted to get the best endocrine therapy. So we chose anastrozole, aromatase inhibitor over tamoxifen. She did have some osteopenia, so we prescribed bisphosphonates. She struggled with this, had arthralgias, and she works with her hands as a hairdresser. So that was something that was very bothersome to her throughout her treatment course. She's a very compliant patient, yet she will do what we recommend, but we definitely, wanted to get her off of therapy if possible. But unfortunately, these are the results. That yes, she was likely to benefit from extending endocrine therapy, that if she stopped at 5 years, her risk of developing metastases in years 5 to 10 would be 10%. But if she continued therapy for another 5 years, that number was reduced by 2/3 to about 3.5%. So she saw these results and very much wanted to continue therapy. Despite the arthralgias, all of it, she wants to continue, is 100% completely on board.
Mm-hmm. And she wants to continue because while she was being treated and going through all this, she had 2 sisters that were diagnosed with breast cancer. And so, of course, we're rushing to make sure that we've done the appropriate genetic testing, and we did, and it's all negative. So I think when she saw these results, it wasn't quite so bad for her. Like, she definitely wanted to stop, but I think in some ways this gives her some extra reassurance, that she's doing everything that she can.
Right. And I just spoke with her the other day, and her sister is going to lap her. So her sister is going to be done endocrine therapy before she is.
Oh.
Yes.
Oh.
But that's life, right?
That's
we take the information.
Love.
Yes, exactly. Everybody's breast cancer journey is different. Siblings. So it's important to, not every patient is super compliant, right? And I don't like to describe patients as compliant or non-compliant, because we're all just humans and time goes on and life gets in the way. And so there are many patients that discontinue extended endocrine therapy for all sorts of reasons. It might be side effects, but it could just be, time has gone by and you've been taking this pill, once a day for 5 years, and it's difficult to know whether something is helping, because it's helping if you don't develop the recurrence. But along the way, it's hard to tell whether you really need it or not. And so that is one reason why patients discontinue. So it's important to get our patients on board if we have made that recommendation to continue with endocrine therapy for another 5 years. And so in that same study that I had referred to earlier that was published in March with the surveys pre and post BCI, 82% of patients surveyed said that if they were recommended extended endocrine therapy, they are more likely to be compliant based on the BCI results. And that makes sense, right? It takes that, I'm not sure if it's helping, to, oh, it's definitely helping. And so they're more likely to not only just say they will sign up for extended endocrine therapy, but actually continue with it for years, 6, 7, 8, 9, and 10, which can be hard to do. Another case. All right, so in this case, we have a patient who's 63 years old at the time of diagnosis. Katie knows her well.
Yeah.
Node negative. We'll discuss why in a bit. Her tumor size, medium tumor size, 2.5 centimeters, but grade 3, estrogen and progesterone receptor positive, HER2 negative. Ki-67, 22%, and that oncotype recurrence score of 48, right? That is high. You know, when we kind of set our cutoff at 26, 48, high. We recommended chemotherapy. She took one cycle and it didn't even end up in the hospital. Wasn't like that, but just decided she did not want any more. So we did not give her any additional chemotherapy, but she was willing to start endocrine therapy. And so she has been on anastrozole. She developed osteoporosis, and after some initial resistance to taking bone-directed therapy, she ultimately started therapy with Boniva, and she remains on anastrozole and ivandronate. And we ordered BCI 4.5 years after diagnosis. And these were our results. So predictive, yes, she was likely to benefit from extended endocrine therapy. She stopped at 5 years, about a 14% risk of stage 4 metastatic disease. But if she continued for another 5 years, that is reduced to 5%. And when she saw these results, she was on board. You know, she was completely on board. She saw these numbers and they made sense to her. And while one might think, because of how she started her breast cancer treatment journey, that she might be less likely to comply with recommendations, when she saw this, she wanted to continue. And at her follow-up visits, she still feels the same way.
Yeah, when you told me this, I was shocked. She gave me palpitations. Okay, I tried so hard to get her to do chemotherapy. I know you did too. You met with her multiple times, and I did. And when she decided to stop, I was unreasonably crushed. So I was really shocked when you told me that she decided to continue. I think that's wonderful.
Yeah, absolutely. She's, you know, she made it this far, and I think she also recognizes in the back of her head that she had made the decision not to take chemotherapy, although we discussed that influences the first 5 years more, but seeing this, she was just, 100% on board.
Yeah, I think she really trusts you. I think over time she's just built that trust in like what we do. And that has helped. Yeah.
Right. It does take time. And it also takes, you know, we'll talk about this in a bit, planting the seeds, like knowing what's coming next. Sometimes in the beginning of treatment, everything's happening so quickly. You know, the recommendation for surgery and then for chemotherapy and all of this. But in our decisions about extending endocrine therapy, we have more time over which to develop a relationship and introduce these concepts and introduce the idea of this type of testing. So going back to the registry study, when we talk about patients and their willingness to comply with recommendations for extending therapy, it's important to note that patients also change their mind. Right? We get very set as providers, as patients, in what our expectation is. And if our expectation is that we're only going to take endocrine therapy for 5 years, and someone suggests that they should take it for 10 years, that may be met with a lot of resistance. But when they see the BCI report, they are more likely to continue with therapy. And in this study, 45% of patients changed their minds related to extending endocrine therapy. And they felt good about their decision. It wasn't just, you know, dreading this change in how they were going to make a decision. It's that they made the decision and they feel that it's the right decision. Providers also feel the same way. We're a difficult group sometimes. You know, like we talked about earlier, we like to look at what's in front of us and make decisions, and there's a sense of pride in that I think sometimes we get caught up in. But with this genomic test, about 40% of providers felt confident and good about their recommendations. So that is why it's been incorporated more into what we do. Okay, so this case. So I wanted to show you this case because I think it also highlights that it's not just a piece of paper that tells you what to do or a test that tells you what to do. It's a test that helps us make decisions together, the provider and the patient. So this was a patient, 51 years old, 3.7 centimeter, node negative, grade 1, strongly estrogen and progesterone receptor positive tumor, HER2 negative, Ki67 1%, oncotype recurrence score of 21, decided not to do chemotherapy. She had side effects of endocrine therapy. She started with tamoxifen, but then switched to aromatase inhibitor, including hot flashes, developed some mild osteopenia. She was doing okay on therapy, but would have rather stopped at 5 years. That was her expectation, was that she would probably stop at 5 years. So we ordered BCI 4 years after diagnosis, and this was our result. That yes, she would be likely to benefit from taking her aromatase inhibitor for another 5 years, but that if she stopped at 5 years, her risk of distant recurrence in years 5 to 10 would be 2.4%, reduced to 1% if she continued endocrine therapy. So looking at this and discussing this, she ultimately decided to stop at 5 years because she didn't think it was worth it to continue for another 5 years for a 1% or so benefit. And I supported her in this decision because I felt that it was an informed decision. She knew the decision she was making and felt comfortable with this. So how do we work together as physicians and our nurse practitioners or PAs? How do we actually do this? Well, one thing is that we decide on when to use this tool and how to go about doing it. So who is seeing the patient? If I'm seeing the patient at year 4, I will order it. If Katie is seeing the patient at year 4, she will order it. And both of us introduce the idea that we plan on ordering this test in the future earlier in a patient's treatment course, but we don't actually order it until year 4. We make reminders in the chart, which helps us. And then whoever orders it, we make sure to close the loop and have a follow-up visit about 6 weeks later to discuss the results. For me, I request a telehealth visit, unless a patient really wants to come in, a telehealth visit about 6 weeks after ordering the test to discuss the results.
I think that one of the things that we do that's very helpful is Dr. Callahan will create a plan, right? There's the initial plan in the note when she first sees the patient. It's just kind of like a summary of what this patient's treatment course is going to be and what's going to be included. And it can include, we're going to do chemo and radiation, and then she's going to be initiated on this therapy. And then like somewhere under that, it's very helpful then to write that like one sentence or phrase, we'll plan to order BCI. And so every time we're in the know, we see it, because I think it's easy to lose track of time, you know, patients diagnosed and kind of like year after year goes by, and you can forget that this is something that you want to do. And so incorporating it into the plan is kind of like a visual reminder. And then there's also been times where I've wanted to order it and I meant to talk about it with the patient, and then something happened, right? Because patients come and sometimes they come with a laundry list of things and new issues, and it's not appropriate to talk about BCI at that visit. There's other things that need to be addressed. And so then when I'm charting later, I put in the note, we can talk about this at the next visit. And the way that Dr. Callahan and I work is we're often switching, right? So she'll see the patient and then I'll see the patient. It's not a perfect system, but it happens like that a lot. And so if I see the patient and I write, we'll plan to order at the next visit, then she sees that. And that's also a visual clue. Like, it's time to order the test. So that's very helpful. All right, so looking at patient characteristics that qualify them to order this test. They need to have either ductal, lobular, or mixed histology. So something like a neuroendocrine tumor would not apply. They have to have some form of hormone positivity. So some combination of ER and or PR positivity. They either have to be lymph node negative or have only up to 3 positive nodes. Like I can think of a patient right now with 4 nodes that I'd love to order it on, but I can't. So up to 3 positive nodes. Tumor size, T1, T2, T3, tumor grade between 1 and 3. They can be pre, peri, or post-menopausal, have gotten chemo or not gotten chemo. They have to be free of distant recurrence, right? This test is meant to guide decisions to avoid not only recurrence, but distant recurrence. And then they can be HER2 positive or negative. And so I think as we've highlighted, we typically order this test between years 4 and 5. It's not a perfect system. Sometimes it's a little after year 5. Sometimes if the patient is really struggling, we'll order it a little bit before just so that we can really create a plan of care moving forward and know if we have to really double down on side effect management versus just kind of get by until year 5. But between years 4 and 5 is the sweet spot. And then we have had patients who have been a transfer of care who come to us at year 6 or 7, and then we've ordered it at that time as well.
So I think, Katie and I showed you why we personally order this test, but it's not just about us, right? The bigger landscape of medical oncologists, their patients, and advanced providers that should feel comfortable using this test because it's the only one that's recognized by both ASCO and NCCN as a result of accumulating data over years. And this data included 5 predictive studies, which included over 4,500 patients, so large numbers. And we saw that it can help us avoid both over and under treatment, and that we cannot just rely on the pathology report or instinct or whatever it is. But when we're talking about personalized medicine, this genomic test fits seamlessly into that treatment paradigm. And that concludes the formal presentation, but we've left time for questions. And Katie and I would love to take your questions, hear about your experiences using the test.
Great. Thanks, Dr. Callahan, and thanks, Katie, for that. You can go ahead and stop sharing your screen so we can see both of you a little bit bigger on the screen. And we have received several questions in, and we've got a few minutes before our time is up. So I'll just jump right into those questions. The first one is, can you speak to how BCI is different from Oncotype or MammaPrint?
Dr. Callahan?
Yeah, so BCI, the guidelines separate them in that Oncotype is predictive of chemotherapy benefit, and BCI is predictive of benefit of extending therapy. And MammaPrint is prognostic, though not exactly predictive, at least per the guidelines, but is primarily a chemotherapy decision-making tool. Right? Oncotype and mammoprint, primarily chemotherapy decision-making tools. There are different genes that are being looked at. Oncotype is a 21 gene recurrence score, includes estrogen, Ki67, and other genes that are involved in cell proliferation and other malignant behavior. Katie had spoken about breast cancer index and how it's a ratio of the yes-no part of extending therapy. The predictive portion is a ratio of two genes that are involved in estrogen signaling. So in short, they're testing different genes, they're testing different things, because just because somebody benefits from chemotherapy, as would be shown by a high Oncotype score, it doesn't mean that they would benefit from extending endocrine therapy between years 5 and 10. So the tests include different gene sets that answer different questions, and you can't use those tests interchangeably. And this has been looked at even. Oncotype has been looked at along with breast cancer index to see the power, the prognostic power between years 5 and 10. And Oncotype performed very well for the first 5 years, but BCI, even beyond the prediction, was better at prognosticating beyond year 5. So they are very different tests.
Okay, thank you. The next question is, if a patient is tolerating her treatment, why not just extend to 10 years?
I think you don't want to extend to 10 years if the patient is tolerating treatment, if they don't derive benefit from it, right? If a patient is on a therapy, just because they have tolerable side effects doesn't mean that they aren't at risk for an adverse event. And I think sometimes it can be, you get comfortable with a patient on a therapy and they're doing so well and they feel so good. Those risks are always still there, and they might be low in terms of like tamoxifen and a blood clot and endometrial cancer, but bone density loss is still an adverse event and it can become progressive. And if your patient develops it and then you have them develop a fracture, like a hip fracture, because they have that bone density loss, it's suddenly not such a benign thing.
Right. I completely agree. And cardiovascular risks and cognition matter too. Aromatase inhibitors, these endocrine therapies, they add points to blood pressure, cholesterol, blood sugar. Patients are more likely to not be able to lose weight despite how hard they're trying. And those things, they're more subtle, but those are adverse effects that we want to minimize because they play into their cardiovascular risk and then the cognition. I've had patients, start therapy at around 65, and maybe it would have happened anyway, but at 70, they're just starting to forget appointments, lose their ability to multitask, and really change. And I wonder what that estrogen deprivation, what the contribution of that is to that change.
Thank you. All right, we have time for one more question here. I have a patient with a predictive result of yes, with prognostic result of 3.8% with 10 years total of adjuvant endocrine therapy of 1.3 to 1.6%. This doesn't seem to be a drastic change. Patient has developed osteopenia, arthralgia. Can you provide insight in these situations?
Yeah, so this was similar to the last case, I think, that was presented, which is that just because the result says yes, doesn't mean that this is the decision that the patient needs to make. So I think it's a conversation starter when it is like this. The patient might choose to be on it for 7 years, and not go 10 years. You have to ask her, what does this benefit mean to you, and remind them that you're talking about stage 4 recurrence. So as long as they understand that their 1.5% benefit is a benefit in reducing a very severe outcome, then I think it's reasonable to make a decision to stop or to continue. Reasonable people can make different decisions.
Great. Well, that is all the time that we have for. So thank you so much, Dr. Callahan and Katie, for this excellent presentation. I'm going to pop my screen back on here and share it really quick. We do have a QR code, and we would encourage your feedback for all of those who attended tonight's webinar. And once again, thank you so much, Dr. Callahan and Katie. You are free to go. I will leave this QR code up on the screen and hope everybody has a great evening.
Thank you.
Thank you for your attention. Bye, everyone.
Bye.